Hi everyone, and welcome back to Sante Pharmacy Academy, the channel where we make high quality, evidence-based pharmacy education free and accessible for every pharmacist and student out there. Today we're tackling video number 4 in our Ontario Minor Ailments series, Candidal Stomatitis, better known as oral thrush. This is one of those conditions that walks up to your counter more often than you might think. The parent of a baby with white patches, the patient on an inhaled steroid, the denture-wearer who says their mouth just feels a little off. And here's the exciting part. Under Ontario's expanded scope, this is now something you can assess and prescribe for directly. So let's dive in and build the confidence to manage it from start to finish. Before we get into the clinical content, a quick but important note. Everything we share today is for educational purpose only. It's here to support your learning. It doesn't replace your own clinical judgment, the most current official guidelines, or the individual care each patient deserves. We're speaking to the Ontario and Canadian context. Guidelines do change over time, and we have no commercial conflicts to disclose. As always, prescribe within your own scope and competence. All right, with that out of the way, let's get started. Here's our roadmap for today. By the end of this video, you'll be able to recognize the different ways oral thrush shows up, pinpoint the risk factors that set it off, and confirm when it falls within your minor ailment scope. We'll also work through a structured Scholar MAC assessment and the red flags that mean refer, and finally choose the right antifungal and counsel your patient with confidence. Sound good? Let's start with the basics. So, what exactly is Candidal Stomatitis? At its core, it's an opportunistic fungal infection of the lining of the mouth caused by an overgrowth of Candida, most commonly Candida albicans. And here's the key point. Candida is normal resident of the mouth. It lives there quietly in most of us. A thrush happens when something tipped up balance and lets it overgrow. It can look a few different ways. The classic one is pseudomembranous, those creamy white, curd-like plaques you can actually wipe away, leaving a red, something tender base underneath. Then there's the erythematous or atrophic form, red, sore patches, often linked to antibiotics or inhaled steroid that can feel like a burning mouth. In denture wearers, we see denture stomatitis, redness mapped right onto where the denture sits, usually the palate. And finally, angular colitis, that cracking and soreness at the corner of the mouth that loves to tag along. Recognizing which picture you're looking at helps guide your whole assessment. Let's talk about why this happens, because understanding the why makes your counseling so much stronger. As we said, Candida normally lives in balance with the rest of the oral flora. Overgrowth kicks in when the host's defenses get disrupted. Whether that's less saliva, a shift in normal flora, a change in the mucosa itself, or a dip in immune function. Tip that balance, and you get the plaques, the redness, and the soreness. So, who's most at risk? Picture the patient using an inhaled corticosteroid without rinsing or a spacer. That's a really common one. A recent course of broad spectrum antibiotics. Denture wearers, especially with a poor fit or poor hygiene. Anyone with a dry mouth. Patient with diabetes, particularly well when it's not well controlled. The immunosuppressed, HIV, chemotherapy, systemic steroids, the very young and the very old, and smoking. When you spot one of these, oral thrush should be on your radar. Now, the part you've been waiting for, your prescribing authority. Candidal Stomatitis is listed in a Schedule 4 of Ontario regulation under the Pharmacy Act. That means Part A pharmacists and interns can assess and prescribe for it directly. When is it appropriate for you to manage? When you've got an otherwise healthy, immunocompetent patient, a clear clinical picture of thrush, an identifiable trigger like that inhaler or a recent antibiotic, and no red flags. In terms of scope, topical antifungal therapy is your first line tool. You'll also want to address the underlying cause, document your assessment and your reasoning, and look in the patient's primary care provider per your local process. Clean, structured, and well within your wheelhouse. Okay, let's put that into a structured assessment using a Scholar map, a framework you probably already know and love. Start with symptoms: white plaques, soreness, burning, altered metallic taste. Characteristics: do the plaques wipe off? And is there redness underneath? History: any prior or recurrent episodes? How about onset? Sudden or simmering? And what came before it? Location: tongue, inner cheeks, palate, or under a denture. Aggravating factors: inhaled steroids, dentures, dry mouth, antibiotics, and remitting. What, if anything, they've already tried. Okay, then the MAC. First, medications. And pay close attention here because inhaled steroids, antibiotics, and immunosuppressants are all relevant. And if they are on warfarin, that interacts with one of our treatment options. Allergies, any azole or antifungal sensitivities, and conditions: diabetes, immunosuppression, HIV, malignancy. Work through these and you'll have everything you need to make a safe decision. Now, the most important slide in the whole video, the red flags. These are signals to step back and refer. First, immunocompromise, HIV, chemotherapy, transplant, or systemic corticosteroids. Second, any difficulty or pain with swallowing or pain behind the breastbone. That raises concern for esophageal candidiasis, which needs systemic treatment and a physician. Third, recurrent or treatment. This is the refractory cases. Fourth, and this is subtle one, thrush with no identifiable cause, because that can be the first clue to an undiagnosed underlying condition. Fifth, a patient who's systemically unwell, or an infant who's feverish or not feeding. And finally, a white lesion that doesn't wipe off. That is not thrush until proven otherwise. Okay, here, watch out. When in doubt, refer. That's good medicine, and it protects your patient. A white plaque that doesn't rub off should be referred to rule out leukoplakia, lichen planus, or malignancy. Great. Let's say your patient is a good fit. Treatment isn't just the prescription. The non-drug piece is where you prevent the next episode. If they use a steroid inhaler, coach them to rinse, gargle, and spit after every dose, and to use a spacer. This one tip alone prevents so many cases. For denture-wearers, it's daily cleaning, taking them out overnight, and checking the fit. A poorly fitting denture is a setup for recurrence. So don't hesitate to refer to a dentist. Keep up gentle oral hygiene with a soft brush and replace that toothbrush once the infection clears. Address the bigger picture too, glycemic control in diabetes and dry mouth where it's a factor. If you're treating a breastfed baby, treat the baby and the mother's nipple together and sterilize bottles and pacifiers so they're not passing it back and forth. And if you're seeing angular cheilitis or recurrence, keep iron, B12, and folate in the back of your mind. Now the prescription itself. Your first line is topical antifungals. Nystatin oral suspension, 100,000 units per milliliter. For adults and children, that's 4 to 6 milliliters, so 400 to 600,000 units. Switched around the mouth and then swallowed 4 times a day for 7 to 14 days. For infants, 1 to 2 milliliters 4 times per day, placing half the dose in each cheek. If Nystatin isn't the right fit, your topical alternatives are clotrimazole 10 mg Thrush, dissolved 5 times a day in patients about 3 years and up, or miconazole oral gel or a buccal tablet once daily. Okay, clinical pearl here. Tell patients to keep going for at least 48 hours after symptoms clear, so the infection doesn't bounce right back. And watch out, miconazole interacts with warfarin. It can raise the INR, as well as with statins and sulfonylureas, with a choking caution in infants. Oral fluconazole for moderate to severe or refractory disease is escalation territory. That generally means a referral rather than a minor ailment prescription. Okay, a few populations deserve a tailored approach. In infants, Nystatin suspension is your go-to, and remember to treat the breastfeeding mother's nipples at the same time and sterilize feeding equipment. In pregnancy and lactation, topical agents like Nystatin are preferred, and we steer away from systemic fluconazole, especially high doses or in the first trimester. For denture wearers and older adults, the focus is denture stomatitis, rigorous denture hygiene, out overnight, and a refit if it's ill-fitting. And for patients with diabetes, optimize that glycemic control, while the immunocompromised, as we said, fall outside minor ailment scope and should be referred. Let's bring it home with counseling, because how you say this matters as much as what you prescribe. Tell your patient to swish Nystatin around the mouth and hold it as long as they comfortably can before swallowing, ideally after meals. Stress finishing the full course and continuing for about 48 hours past when they feel better. If they use a steroid inhaler, reinforce that rinse and spit routine and the spacer. Remind denture wearers to clean daily and go denture free overnight. Give them clear return advice. Come back if there's no improvement in 1 to 2 weeks, if things get worse, or if swallowing becomes painful. And if you've prescribed myconazole to someone on warfarin, let them know their INR may need a closer eye. Warm, clear, and specific. That's what builds trust. So let's tie it all together in 4 simple steps. Step number 1, assess. Run your Scholar Mac, confirm the diagnosis with the wipe test, and find the trigger. Step 2, screen check. Just check for those red flags and refer if any are present. Step 3, treat. Reach for a first-line topical antifungal like Nystatin and tackle the underlying cause. And step 4, counsel and follow up. Nail the technique, the adherence, the finish the course message, and clear return precautions. Then document and notify the primary care provider. 4 steps, and you've managed oral thrush with confidence. And that's the wrap on oral thrush. If this video make the topic click for you, do us a favor, give it a like and subscribe so you never miss an episode. Everything we make here is free because we believe great pharmacy education should be. Next up in the series, we're moving on to conjunctivitis, pink eye. Another one you'll see all the time at the counter. Drop any questions in the comments. We read every single one. Thank you so much for watching, and we'll see you in the next video. Take care.